Good afternoon and welcome to the next broadcast of the Rheumatology Nurse Practice Google Hangout series, talking about challenging cases in rheumatology. My name is Kevin Lyons. I'm the Executive Director of the Rheumatology Nurses Society, and we'd like to welcome you today's broadcast with our faculty, Eileen McCullagh and Monica Richey. Hey, Eileen. Hey, Monica.
Hi,
Hey,
how are you
Kevin.
guys?
So this is a continuation of a series in our Rheumatology Nurse Practice initiative, which includes the Google Hangout series, dinner programs, as well as a publication that we produce called the Rheumatology Nurse Practice. We actually, our current edition is currently out already. It's the pathophysiology of spondyloarthritis, connecting and differentiating characteristics. So it's a fantastic issue. We actually have 3 more editions, I believe, this year. This is October. We have 3 more editions this year coming out. If you're not receiving these by mail, please visit the RNS website at rnsnurse.org. Click on Education and the Rheumatology Nurse Practice, and you can sign up to receive these publications free. The next one's currently at the printers and should be out shortly. So we'd like to thank you for joining us today. This broadcast will also be available for replay. You can use the same link that you joined us at today for this, and you'll see it shared on our Facebook accounts and other social media accounts. So today, as we move forward, I'd like to have our faculty step forward and take us on today's case study.
Okay. There's a 24-year-old male presenting with a 2-year history of cervical pain, stiffness, and severely decreased range of motion. Symptoms started at age 16, and he developed bilateral hip pain and stiffness. Self-medicated with NSAIDs and muscle relaxants, severe back pain, particularly at night, and severe morning stiffness that improves with exercise. Lab tests were for HLA-B27, that was negative. ESR and CRP were only mildly elevated. X-rays showed no erosions of the SI joints, and the diagnosis is non-radiologic axial SPA. So, treatment recommendations are NSAIDs continuously, hepatitis panel and quantiferon TB gold tests, and both were negative. Patient was started on adalimumab, 40 milligrams subcutaneously every 2 weeks, PT, and we screened for osteoporosis. Now, 1 year later, there's spinal pain that has progressively increased. Inflammation has worsened, along with an elevation in the CRP. Patient is due for a new set of x-rays and MRI. Prior to this, the MRI was negative for erosions. Patient continues on adalimumab, 40 milligrams every 2 weeks with some relief, but is off the NSAIDs due to intolerance. So, what might you expect with doing x-rays now, the MRI and just regular x-rays? What would you think, Monica?
I mean, he might present with erosions, but because this is a non-radiographic SPA, it might still be normal. So it's hard to guess. Plus, he was in Humira, and Humira can't stop progression. It didn't look like Humira worked very well for him. That's why he was still in pain. It kind of didn't do much for him. It's hard to guess. But if this was non-radiographic, you would expect it to see increased erosions or presence of erosions. Because this is non-radiographic, it can go either way.
Right, that's true. And now we have to think about options, of other types of options. So can you think of any?
I mean, technically you could switch within the category for Remicade, or, even so try, because the TNFs is the one that are approved for non-radiographic SPA.
Right.
But besides that, we don't have a lot that is available to our patients with spondyloarthropathies.
Okay, well, I would suggest maybe going to a clinical trial and seeing what's out there.
I mean, that's a great idea. And AS that are spondyloarthropathies are usually have less options. So I'd love to hear from you what we maybe have out there.
Right. So clinical trials definitely are a viable option, But like you said, there are currently very few out there for this population. So the patient would have been, by the way, an ideal candidate for an enrollment in an ongoing multi-center phase 3 trial. Randomized patients would either receive 20 milligrams of Cimzia, which is sort of nimezumab, Begol, every 2 weeks, or placebo. But this enrollment into this is closed at the moment. What was good about it was that the trial was for active disease without X-ray evidence of ankylosing spondylitis. So just like this patient was non-radiographic, they would have been an ideal candidate. And it also provided the opportunity to assess the health outcomes over time and the SI joint inflammation with the MRI. So it would have been perfect for him, but unfortunately it is closed to enrollment. This slide is very helpful. It's the clinicaltrials.gov slide. If any clinician who's thinking they don't know what to do with their patients should go to this, because it would give the inclusion and exclusion criteria, a description of what a study is. In this case, it tells you the title, but it's closed to enrollment right now, and they don't have the study results. It will be posted within the next 6 months to a year. But it would give you the inclusion and exclusion criteria. It would give you the participating sites and how many patients they're looking for globally, basically, because now we do it worldwide.
Right.
So that's something for everybody to keep in mind.
Yeah, now clinicaltrials.gov is something I always go to, and I recommend my patients to go for all diseases. And, you know,
they
sometimes
can tell
you find,
what's up down there.
Exactly.
Okay, so there are upsides and downsides to patient participation. Basically, the upside is most study procedures are free. A nice diagnostic workup, you could have gotten the MRIs for free.
Totally free, yeah.
Spine and SI joints, and all the comprehensive, expensive lab panels. But bear in mind, some of the study procedures, even labs and x-rays, are considered standard of care. And if that is the case, you bill insurance, and patients would be responsible for their copays and deductibles and so forth. But that's minimal compared to how much it really costs. It also provides you with furthering medical science, participating and wanting to give back, and your information being helpful to other people. And there have been, from learning from past medical studies, there have been 3 Cimzia studies already published, and they show similar baseline activity and treatment effect on both ankylosing spondylitis and the non-radiographic SPA. So it's very interesting what comes out of there, not what you think, but what actually comes out. Mm-hmm. And of course, they get more attention, and that can lead to a higher degree of patient satisfaction. But sometimes they fall in love with the research staff, and they forget that they need to go back to their primary doctor to begin with. But that could be a plus, and that could be a negative at the same time.
Yeah, no, it's amazing. The patients that I have recommended, and where I work, we are a research site as well as where you are. And sometimes they even forget that they have to follow up with us and say, oh, I thought, you know, they were just taking, they're doing everything. Yeah.
Exactly.
But they usually love the attention. They love the care that they get when they're doing a research study.
Right. Now, along with that, there's a downside. And the downside is there's a lot of unknowns and knowns. And sometimes there's more unknowns than knowns. Particularly, I'll just run briefly through the different 4 phases. Phase 1 would be first in humans. We're looking for, does it work? And that doesn't have to be in a specific population. So it is dangerous, and it's there's a lot of side effects possibly. You just don't know. There's more unknowns. Phase 2, there's more knowns. It's a specific disease population, so you know how maybe it's going to react in that particular disease population. But you're looking for safety and this most safe and effective dose. So you'll have different doses, and you want to see which one is most safe and most effective. Phase 3, as in the study on this particular patient who would have been good for, they give you a larger enrollment number, so you have more patients in it, but you have to either get a placebo or the actual study drug. So that's the downside of that, being in the placebo arm. Sometimes you can rescue to the known as an open label portion,
Extension.
where you will get the actual drug, but not every study is designed like that. Post-marketing is phase 4. That is a known drug now because it's on the market. Patients recognize it. They like to be part of that because you want to see what is going on in the real world, not the specific inclusion-exclusion criteria. It is the patient with that study disease entity and how it's relating to all the other meds they're on, what they're doing, what they're not doing, compared to everybody. You have probably noticed that a lot of drugs already FDA approved have been pulled from the market. That's because of phase 4 studies. The post-marketing told a different story than the actual clinical trial. So this is a very important phase, and it's broader, and it gives us more real-life data. And of course, there's tight time commitments. I don't know if you've had that experience, Monica, with your patients. They have to adhere to a window of time, and sometimes they don't make those visits.
They don't make it, and it's really tight. You know, they have to show up for almost. I mean, there is some leeway where you can reschedule an appointment or not.
You're lucky.
But you can't. You can keep missing appointments, or it's something that, it's really tight, and it needs to be well controlled. And that's where phase 4 is important, because when we get to phase 4, exclusion criteria are not only present sometimes anymore, and you can try different medications. And that's when you get the real world experience, because it's so tightly controlled at phase 3, what medications they can be in, what's the inclusion and exclusion. But then when you're really using the drug in a clinical practice, that's when you get to know how it interacts with other medications and other conditions that patient may have. That was not included
and has
during
developed
the trial.
That would have excluded them out of there.
Exactly. Yeah.
So, and anyway, briefly, at a screening visit, if they are interested or the doctor refers them, they're going to get an informed consent. That's a big legal document, quite lengthy. They keep getting lengthier and lengthier. More and more is put into them. And that describes everything they were expecting, what is expected of them. They review the inclusion and exclusion criteria. That's important to see if they actually can get into this study. And of course, the free diagnostic workup to see, do they really meet this inclusion or exclusion criteria, because you may screen out because of that exclusion, depending on what it is. And baseline visits, you review your primary endpoints, and you do physical exams, and you do patient-reported outcomes. You do how many meds you're on, and that follows you throughout the study to see what you come off, what you come on, what you started, what you ended. Administering the first dose of medication, as in this patient, they could be dispensed the study medication home because they've already been on adalimumab, so they know how to subcutaneously inject. Otherwise, that's a perfect time for a nurse to teach them how to inject the study medication. Subsequent visits, they're doing the same thing. They're doing physical exams at different intervals. They're checking the drugs to see, you went home with 7. Did you come back with 7? Did you come back with 2? Did you come back with none? Did you take the meds?
Right.
So lots of times, I'm sure you've seen it, drug accountability is a nightmare.
Oh my God, yes. Oh, I forgot this one. I didn't do that one.
Oops, I missed it.
Or they started a new medication through another physician, like primary care, and they never told you. Right. And then they have to drop off the study. So it's really, they are the patients have to be really well thought, and communication between the research team and the patients are absolutely mandatory.
An assessment of side effects and serious side effects, known as adverse events, are very critical. And then, like you said, they may have gone to another doctor. Maybe it's because they were feeling something instead of calling you and letting you know. And then even if you're admitted to the emergency room for a cut on your finger that bled a little bit and they need stitches, you need to tell the study staff. And if you stay overnight, that's considered a serious adverse event, even if it was for that same example, because anything if you're admitted for 24 hours, anything that you're admitted for is considered serious adverse event. It's not related to the drug, but it's still considered that. And that has to go to the FDA. And of course, like you said about the medications coming off, coming on, you have to keep that up. And of course, completing the PROs to see if there's any changes in those baseline patient-reported outcomes. To let us know if it's working. So, how do you determine if your patient is a good candidate for enrollment in a clinical trial? What would you think is an assessment of that, Monica?
I kind of talk about clinical trials to almost all of my patients because they're big research, you know, and at the beginning they kind of turned off just because of the history with research and, you know, things they read in the web and whatever not.
Right.
But, you know, so usually it takes a couple of few visits for them to start understanding that is not what it used to be, that is a much more control and, you know, they get all the attention. And for people who don't have insurance, for example, this is like a godsend because they can get everything. It's perfect.
Yeah.
You know, and even people with right now bad insurance.
Yes.
So, and usually a patient who has run out of options, those are usually the ones that really need research drugs, like even with AS or lupus or RA, you know, they tried the gamma and they failed and you have nothing. And that's a perfect candidate for research.
Yes, that's exactly. I'd agree totally with your assessment. And then how do you know which trials your patients may qualify for? But clinicaltrials.gov eliminates that a lot because you look at the inclusion, exclusion, including the patients, depending on how their grade level is. Do they know themselves? Oh, I'm excluded because I have this or that, whatever. And then, of course, who can you contact to find a potential match? Clinicaltrials.gov, again, lists all the investigator involved in it. But do you have people you reach out to at your institution?
We do, because we have our research coordinators here. And so, if you know, I usually go to them, hey, I have this patient here. And each coordinator has a different study. So they would tell me who is dealing with that particular study at a time. And then I invite them in the room and talk to the patient. And the research coordinators are really a good resource because they know how to talk to the patients, you know, and kind of calm down a little bit of the fears that they have of the research. And sometimes I have patients who just went to clinical trials say, hey, how about this one? And they come in with the information for me. It's like, can I sign up for this trial? You know?
Exactly. Yeah.
But some patients are more proactive than others. But the research coordinators, the nurses in research, there's a lot of research that's done now. And nurses like you, Eileen, are excellent for us to have it as a resource, you know, because you really understand all the ins and outs of research is not as simple as people think. And there's a lot of that goes into the whole paperwork and all the monitoring and things like that.
Also, with the shortage of rheumatologists that we are expecting in the near future, people like you need to be the principal investigator more than the MDs going forward.
Yeah, I think the pharmaceutical companies are picking up on that.
Finally.
And they're kind of being a little bit more open to have nurse practitioners or principal investigators. Very few accept them, but some do.
And I'm a dinosaur because they're trying to do away with research nurses because of the expense and so forth. But that's a fine line.
I hope not.
Yeah. But that's another thing for another day. And of course, the community you know, rheumatologists really need to look at clinicaltrials.gov. So I hope the nurses listening today will edge their physicians in that direction.
Yeah, no, I think research is something interesting, something that nurses sometimes are afraid of, just because we're specifically trained for it.
Yeah, exactly.
But it's a new world, and nurses need to get their foot there and research and understand and know more about it.
Right. Okay, I guess we're done.
I guess so.
That was great. Great. Thank you so much. And I love the inclusion of discussion surrounding workforce and the need of having, you know, the RN and the APRNs involved in clinical trials, and how that's going to be ever more important as, you know, there's not a slowdown of new treatment therapies and options coming onto the marketplace, but there's definitely the decline of rheumatologists there to as the PI is going through those processes.
Right.
So thank you so much, Monica and Eileen. I'd like to let everyone know that our next broadcast is going to be on Thursday, November 16th at noon. And definitely keep in touch with us on our Facebook page, as well as our website at rnsnurse.org/RNP, where you can also sign up for the Rheumatology Nurse Practice publications. We would love to get those out to you on direct mail. We also have all copies digitally online. We have other resources online as well, including some free continuing education offerings for nurses, and information about some upcoming events that we have coming. We have a couple of big events. Our conference next year will be, our annual conference will be in August at the Gaylord Texan in Dallas, Texas. We also have an event coming up, just to give a sneak peek, sometime in February, probably the first weekend of February, more than likely in San Diego, but I can't give you more information than that right now. But keep in touch with us for that. And we'd like to thank you for joining us. Monica, Eileen, any closing thoughts?
No, research is part of the nursing universe, and so get your feet wet.
Right. And explore it if you're interested in that kind of career too, because we can use more of this insight.
Awesome. Fantastic topic today. Thank you both so much, and thank you all for joining us. And also, this video will be available for replay at the same links that you used to see this video. So please share with your friends, your colleagues, and share the education out there. Thank you, and you have a great day.